And so essentially what you're seeing right over here, essentially what you're saying is this is actually approaching it from a more lateral position because this is the anterior superior iliac spine, this is the ilium. So again, what you're seeing right here, this superficial muscle is sartorius, and then essentially you're seeing the iliacus. And iliacus will basically kind of go with iliopsoas, and that'll be interchanged. And essentially you're seeing this big, bright white line. And you'll see one kind of coming up, one coming down. That's your fascia lata. That's actually more superficially. This is your fascia iliaca. And then essentially what you're looking at is a needle that's going to be approached from lateral to medial. And then what you're going to, and so here you can see basically our needle approaching. And then essentially what we're trying to do is once we get to the point to where we're actually at the iliopsoas, obviously you don't want it to inject in the muscle, so if you're in a little bit too far, you just pull back a little bit. And then what you'll see is basically just a hydrodissection of this fascial plane. And then you'll basically just see that muscle dissect, and you'll just see it dissect a little bit more. And then from this point, you can just basically push your needle in just a little bit further. You can apply more anesthetic. Now, in terms of doing this procedure, usually what you should do is you should give about 30 cc's of bupivacaine when you're doing this. So obviously any long-acting anesthetic will do. Essentially though, we have bupivacaine 0.25% at Kings County. I'm not sure what we have at SUNY Downstate, but that's essentially what you'll be using. You can use a spinal needle for this procedure. You don't have to. Thank you, Dr. You can use a spinal needle, but you don't have to on this procedure. But essentially what you're going to be doing is you're just going to be going until you get to that fascial plane. Now, a couple tips that you can end up doing. That's okay. Anything else for that? Let me just say, I can just kind of go through this right here. Yeah, this is pretty much it. A couple things that you can kind of do to help you, and basically to help your success. Now, a lot of you have kind of seen when I end up doing digital nerve blocks, I actually place a tourniquet proximally to make sure that all the lidocaine stays distally. Now, in that same kind of motion, what you can do is you can actually try to apply pressure distally to your actual insertion, and that way will force the the anesthetic to actually migrate proximally. You need to use a fair degree of a fair amount of anesthetic, so it's going to be about 30 to 40 cc's. It's not uncommon for people to use up to about 60 cc's when doing this because, again, you're trying to actually maintain and you're trying to achieve a proximal migration of your anesthetic to get to the lumbar plexus. Again, most of these are going to be lateral to medial. You're probably not going to be going from this direction anatomically and ergonomically. It's just going to be easier. And then if you end up having obese patients, what you can always do is you can try to outline that area of the iliopsoas muscle, and you can attempt to try an out-of-plane approach, and that may make it a little bit easier because you may have a lot of soft tissue that's getting in the way. Any questions on this one? This one's going to be a little bit more difficult just because of the fact that we don't do these as much, and we don't kind of go over this as much as actual shoulders. I probably didn't kind of go through too much on the actual ultrasound positioning, but the ultrasound positioning should actually go in the plane of the ilioinguinal ligament. So essentially your probe on the lateral approach should be a little bit more inferiorly, and then medially it should be a little bit superior because you're going from pubic symphysis to ASIS. Yes?
The neuralgia parasitic patients, can you just hit the lateral frontal cutaneous nerve to block that?
Yeah, you can, but that's going to basically be a different kind of approach. You're going to come between the tensor fasciae lata and the sartorius, a little distal to the ASIS. But it's going to be essentially kind of along the same fascial plane. But when I do that one, I basically just kind of try to isolate just that nerve in particular. And usually those patients are ambulatory. They get upset when I knock out their femoral nerve.
Exactly.
Yes, sir.
Kind of just a random piece of advice for the juniors. On my anesthesia rotation at Lutheran, got to see a bunch of fascial blocks on the belly. So you get to see what it looks like when you inject into that fascial plane, see what it spreads like. And I found that was helpful that I've seen that. That's all.
There's a lot of good resources out there that you can end up using to kind of get a better idea. If you want to, I'm more than willing to talk about this further. I think that's it, right? We just want to do like this one. Yes, Dr. Reagan. Yes, Dr. Okay. All right, thank you.